The mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. So in today's session, just a brief introduction about the moderators. So my name is Fide Pineda Sandoval, and I am the TTA manager at the National Center for Health and Public Housing. And with me, we also have Olajumoke Oladipo. She is our health communications and research analyst. You can also call her Jumoke, and she will be helping us with the logistics of today's session. And we also have our special speaker for today. His name is Dr. Jose Leon. He is the Chief Medical Officer at NCHPH. And just some brief background information about Dr. Leon. He is also the Chief Community Health Officer at La Maestra Community Health Centers, where he leads the development and implementation of a comprehensive community health strategy that aligns with the organization's mission and improves patient outcomes. And also here at NCHPH, he has provided training and technical assistance for over 12 years, especially for community health centers serving public housing populations. He is also a national leader in population health and chronic disease prevention, contributing to major initiatives such as the American Diabetes Association's Practice Committee and the review of the standards of care in diabetes. And without further ado, I will pass it on to Dr. Jose Leon to get us started with the session.
Thank you, Fide, and hello, everyone. It's such a great pleasure to be part of this conversation. This is an echo model session. So for those who are new, this is very interactive. We would like to get information from all of you about challenges, promising practices, what you're doing to improve the services that you provide to your patients, as well as how you address any nutrition or obesity challenge that you have with your patients. We are created this as this is a hybrid kind of echo session where we are going to have a presentation, but at the same time, we will have time for interaction. The learning objective, we are going to be for the next 4 weeks going over one of the priorities of HHS and the administration, and how to improve the nutrition of our patients and decrease the percentage of people with obesity and overweight, or who are also overweight, and many of them with some chronic medical conditions such as diabetes, hypertension, some type of cancers, etc. So these are our learning objectives for today's session. So I hope that we can get together for the next 4 weeks, making sure that we have the interaction that we need. We also, or in my case, I would like to just remind the audience that we have participants from who are non-clinical staff as well. So the respect to any opinion on anything that they can mention is always important for everyone, because they do a lot of the hard work in the communities. So it's just an ask, to make sure that we have an environment where we respect each other. Next slide, please. And let's get started from the very beginning. I'm quite sure that everybody has heard about this guy, who is the father of medicine and the father of the of prevention in general. And in the 5th century, he came with one of the most important sentences that we know that we try to practice, and yet we can't sometimes get the message across when we have conversation with our patients. But in the 5th century, he said, if we could give every patient the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. So this is the main principle for those who have direct contact with patients, specifically related to nutrition, healthy practices, and everything that it has to do with nutrition, exercise, and to prevent our patients to be overweight or obese. Next slide, please. Why is this topic so important? Well, we've heard that there are some new drugs that are being used that they were not created or they were not produced to deal with patients with obesity and or patients who are overweight, but we know that they can help our patients to manage their weight. And because of these drugs, we see some signs of decline when we see the percentage of patients with obesity or patients who are overweight in the United States. Next slide. However, the United States continue to be one of the countries in the world with a high percentage of patients with obesity. The latest information that I could find is from 2026, which is this year. And according to the literature review, almost 43% of the population in the United States are either overweight or obese. Next slide, please. So what does it mean? Well, when we translate the percentage, we know that more than 2 in 5, which is 20% of our adult patients have obesity. And we know that there are some other non-clinical factors affecting our populations. Race and ethnicity is one of them. The access to healthy food, issues like housing instability, patients who have no insurance or are underinsured are more likely to be obese and find challenges to have a proper or adequate nutrition. And for those who are interested in the national picture, obesity accounts for nearly $173 billion in medical expenditures, and this was in 2019. So it's a huge public health crisis. It's a huge problem for our patients, and it's a great problem or a big problem for our health centers and safety net providers trying to deal with our patients and making sure that they receive all the resources that they need to make sure that our patients have an ideal weight and therefore they don't have to deal with other conditions that are linked to obesity. Next slide, please. So since this is very interactive, this is our first question for you. We can use the chat box, and our team, Fide and Shimoke, will take a look at your responses. But which statement best describes the etiology of obesity? We have 4 options. Obesity results from a genetic predisposition. Psychological factors can override the effects of genetics in the etiology of obesity. Obesity is the result of complex interactions between genetic and environmental factors. and genetic factors are more important than environmental factors in the etiology of obesity. We are going to provide some seconds for you to respond to this question, and let's try to find the best answer for the question.
Yeah, I think so far we received responses from Christine, Espen, Kelly. Thank you so much. And I think you're all correct. The answer is C. Obesity is the result of complex interactions between genetic and environmental factors.
Excellent. Thank you so much. And that's the right answer. Next slide, please. Definition of obesity. We know that there are a few definitions depending on who you go to and the organization that you the medical organization that you would like to get the response from. But we have different definitions, one from the World Health Organization, one from the Centers for Disease Control and Prevention that focuses on body mass index. We have a definition from the Obesity Medicine Association. And for this one, or for this session in particular, we are going to focus on the BMI. So as we know, anyone with a BMI over 25 is considered overweight, and someone with a BMI over 30 is considered obese. There are different ways to measure, many doing the clinical part of the conversation with patients know that we also need to take into consideration race and ethnicity. Sometimes the BMI, we need to adapt it to the Asian populations, for instance, because due to genetic factors, we cannot rely just on the BMI. But this is what we know, and this is what we are going to have. We are going to focus on the next 4 weeks. Next slide. So another question: what raises the risk of overweight and obesity in your populations? Let us know in the chat what are the risk factors that you see in your populations, the issues that they face, and anything that is related to any other risk that you know about patients who are overweight or patients who are obese.
Okay, we have a response by Adriana. Cholesterol, blood pressure. Lisbeth says CVD, diabetes, stroke.
Excellent. Thank you so much. Next slide. So here, we are going to focus on the causes of obesity. I totally agree that the conditions mentioned are part of the interaction, on the physiological interaction in the body. Some of them are complications of obesity or patients who are overweight. And but in reality, this is a complex condition, like we are analyzing any other chronic medical condition. We know that the diet is very important. So our patients have different diets because different challenges or because different backgrounds. And if you would like to analyze the diet of a patient, you will have to take into consideration their ethnicity, the physical activity that they have, whether or not the patient is able to exercise, not because sometimes the patient doesn't want to do it, is because sometimes the environment where the patient lives in doesn't let the patient uh, exercise. So all these issues like family history and urbanization, as I mentioned, we work with patient or with populations or people living in public housing, and for them it's more difficult to exercise because of the different environments or the different environments in the communities. Sometimes they don't have safe places to go. We have health centers developing exercise programs in their clinical settings just to make sure that they offer a space to our patients to exercise. We know the socioeconomic status. Our patients sometimes are dealing with more than one job. They don't have time. We know as well that we have some other behaviors, compulsive disorders, etc., um, affecting our patients, and sometimes how the patient feels. So there are some psychological factors as well that are linked to obesity. Next slide, please. What we know is that obesity is a medical condition, that there is ICD-9 and ICD-10 um, codes for the condition. We know that there is a pathophysiology. We know that this is the interaction of some hormones and some other organs working together. If we don't have the right conversation with our patient, we are going to see that this interaction is going to cause our patients to be or to get obese or overweight. We have gone through the contributing factors. So let's keep that in mind when we have conversation with our patients. It's not that our patients are lazy. It's not that our patients are overeating. It's not sometimes we need to take this into consideration. The societal factors as well as the pathophysiology of the disease. Next slide, please. So this is what we need to know. We know that, as it was mentioned for some of the participants, there are some conditions that can increase the risk of, of obesity, specifically because of the poor nutrition or the physical inactivity. And we have some patients who are obese, who also have depression, or who have type 2 diabetes, or heart diseases, and some cancers that are also linked to the fact that our patients are obese. We know that when I was reviewing materials for this specific presentation, are fewer than 1 in 10 children and adults eat the recommended vegetables. About 25% and even fewer adolescents meet the US physical activity guidelines that we will be reviewing in our fourth session. And as many as 40% of adults and 20% of our adolescents have obesity. And there are several public health approaches, education policies, environmental strategies, and yet we still need more. We need to keep working on this because if we focus on the nutrition of our patients, making sure that they get their ideal weight, as our philosopher in the 5th century mentioned, then we are going to have a healthy or healthier population. Next slide, please. Again, I'm not going to go through the pathophysiology of obesity. Is just for this particular presentation, we are going to focus more on the challenges and promising practices, but we know that there's different organs and systems in our body working together. And when we have more calories, or the amount of calories that we eat is greater than the amount of calories that we spend or that we don't use, then there is an inequality. And when there is an inequality, or when there is when the equation is not, the balance is moving through one direction or the other one, then we are going to have patients who are going to be obese, or patients who are to be have poor nutrition and other conditions. But in reality, just let's keep in mind that there is a pathophysiology of the condition. Again, just to mention that this is not, and this is something that I would like to highlight and underline, that we cannot blame our patients for this condition, because there are several factors behind obesity in the United States and around the world. Next slide, please.
Dr. Leon, we have a patient that she provided a comment in the chat saying that they have a larger amount of hypothyroidism in her area. So.
Okay, yeah, the hypothyroidism is one of the conditions, that we've been sometimes mentioning in other sessions when we address metabolic disorders. And either in this case, some patients, they say that they have a thyroid that is not working properly, and that is the reason why the patient is getting obese or is gaining weight. There has to be a physical examination of the patients, analyze the lab results, and making sure that we are addressing all these conditions that can also cause a patient to be overweight or obese. This is one of many, and yes, thank you so much for sharing that. Next slide, please. Oh, before you move on, what are some complications of obesity? Now that we've been talking about obesity causes, we've been talking about pathophysiology, we've been talking about some factors or non-clinical factors, but now we have a patient who is obese, for instance, and you are having a conversation with this patient, and you would like to highlight the reason why this patient needs to lose some weight, and you are explaining the complications, either some acute complications, some complications that the patient will develop in the future. Next slide, Fide, please. So we have different conditions associated in the very beginning. Some of our participants mentioned some of them. The list keeps going and going and going, because we are making progress in different areas, and we see the association sometimes between being obese or overweight and other conditions. But as we know, there are several. We can mention the type 2 diabetes, heart conditions, asthma, hypertension, stroke, some gallbladder disease, and some cancers. And so if you have a patient with family history of cancer or of any other condition, this is one way to have a conversation with a patient, talking about the risk that they have because of their family history, about family or relatives being uh, uh, or having diabetes or stroke in the past or hypertension. So this is a really good opportunity to start a conversation with patients, making sure that they understand the reason why they need to lose some weight. Sometimes patients, the health literacy level that they have is not adequate enough, and patients do not understand the interaction of chronic conditions and obesity, and we need to make sure that that we have a conversation with our patients, making sure that they understand the reason why we want them to lose some weight. Next slide, please. So now that we have discussed the risk factors as well as the complications. So we are going to get into the goals of weight management. So when we have our conversation with our patients, we need to let them know why we are asking them to lose some weight. If you have a patient with diabetes, for instance, there is the standards of care mention a percentage of weight that the patients need to lose, when they are starting treatment, and just by losing some weight, getting into some medications and increasing activity, all these measures help our patients to feel better and to get better and to avoid any of the chronic medical conditions that we've been discussing. Next slide, please. I'm going to stop for a moment and I'm going to ask all of you if you can share with us what are the barriers and the challenges, of weight management in your communities. Even though we serve patients in areas where we have some limitations, sometimes these challenges are different, either because we serve patients with different ethnicities or different race or different income, or they have other barriers like language barriers, or they do not understand the what you are discussing with them, or the patient has no insurance or is underinsured, or the patient doesn't want to do it, or the patient has some psychosocial issues. Let us know. Let us know what you see in your community.
I have a response from Kelly,
Mm-hmm.
who says access to nutritious food, home life challenges, lack of knowledge, mental illness, body image challenges. And Elizabeth says busy work schedules, limited exercise, family responsibilities, and lack of health insurance.
Correct. All those are barriers and challenges that our patients are experiencing, and we need to deal with all these issues as well. With our patients, we have to have an approach where we include our clinical and non-clinical staff to address each of these issues. It's not just to mention or to prescribe medication to our patients. It's not just to recommend them to exercise if they don't know how to exercise. It's not that we are telling them that they have or they have to pick better food options if they don't have access, because those are expensive. So this is interesting, and thank you so much for sharing your challenges and the challenges that you see in your community. Next slide.
Oh, Christine also added limited education and patients getting their information from social media.
That is true as well. Yes, patients are receive information from different sources, many of which are not the right sources of information. And we see patients saying, "Oh, I saw this diet on Facebook," or "and I saw this, and do you recommend this?" And sometimes, or many times, these are not um, approaches from a clinician or from someone who is knowledgeable and can provide the right advice, and they don't have the expertise to have conversation with their patients. So I agree that social media is also a big challenge, especially for adolescents and young adults who are more likely to be on the internet and social media and looking for responses, for different responses. But going back to the barriers or challenges to weight management, all these that we have listed, I would like to mention something on this list, which is the weight bias and stigma. This is a big issue. In fact, our second session next week is going to focus on weight bias and stigma. And we're going to go over some of the recommendations from the American Diabetes Association about how to address these when we have conversation with our patients, as well as the structural stigma. Sometimes without noticing, we clinicians can also be biased and to provide the services to patients because we also have, in addition to the knowledge, our own ideas. So let's make sure that we also address that, and we are going to focus in the next session on weight bias and stigma. We are also going to focus on motivational interviewing, how we can talk to our patients, how we need to listen to them, making sure that we understand and find a way. Well, the patient needs to find a way of something that is likable so they can start a nutrition program. Next slide, please. So this is a really nice slide for those who are having conversation with patients and how you can start the conversations and what is going to be the expectations when you talk to your patients. Is making sure that those providing services to the patients understand the different topics or the different items that you will have to have, in mind when you have conversation with your patients. And the most important one here is to make sure that we see our patients as individuals, unique individuals. Each patient is different. Each patient is going to tell us a different story. Each patient is going to have different challenges. And so let's make sure that we listen carefully to their patients, and when we have a conversation with them, that we are providing evidence-based advice, that making sure that we are having conversation with them, making sure that we are individualizing the treatment guidelines for our patients, providing the appropriate resources, making sure that we address or our team addresses the barriers or challenges that they have, and making sure that the patients adopt a healthy behavior. So I really like this slide for those providing services, clinical services to our patients. If you have sometimes since we're sharing this, go over this slide because it's really interesting just to make sure that we keep in mind how to have this weight management conversation with our patients and how we set the expectations with our patient from the very beginning. Next slide, please. So another question, which patients should providers engage in a conversation about their weight? Patients who are overweight with an BMI between 25 to 29.9, or those patients who are obese with an BMI greater than 30, or patients with waist circumference greater than 35 inches, or those who have metabolic syndrome or any other complication. Adriana says BMI greater or equal than 30. Christine is saying no. Adriana is saying 29.92. And Kelly is saying, I feel like any of these would be cause for a conversation. And the right answer is all of them. Is part of the conversations that we need to have with our patients, even if our patients are not coming because they are looking for a program to lose weight. We need a part of the clinical conversation with our patients, and some of the issues that we need to analyze is whether or not our patients are eating properly and having an adequate nutrition. And so let's make sure that we need to have a conversation with all our patients about nutrition and how they need to, how they have to eat. We need to ask them what they eat. Sometimes you can see patients who are not overweight, and yet when you have conversation with them, you see that they are having a diet rich in carbohydrates or poor in proteins, and they don't show in reality that whether they are obese or they are overweight, but they are not eating properly. And in order to prevent any complication or any issue with our patients, we need to find out how they are, what they are eating, how they are eating, and how often, and the amount of water. Everything is important. So we have, it's not just to have a conversation with our patients who are already overweight or obese, or they already have a chronic medical condition. Remember that we would like that our mission is to prevent some of these conditions as well. Next slide, please. Then when we have a conversation, when we start a conversation with our patients, the United States Preventive Service Task Force recommended 5 A's. We know that for other conditions, like for those smokers, we can also use this method, on how to assess the need of the patient, or whether the patient is able to start a nutrition program. We need to have an agreement with the patients. We need to make the arrangements. Then we start providing advice, and then and in the follow-ups, we need to assist our patients. And this 5A methodology applies to other conditions. I mentioned those who are current smokers or who are trying to stop smoking, for instance, for our patients who are overweight or obese, etc. Next slide, please. Then when we have conversation with our patients, we know that if when we go over the personal history and the patient says, no, I don't smoke, I try to eat healthy, I do this, I do that, we can adapt or modify their diet depending on what they're saying. And if the patient has physical activity, an adequate physical activity, we're going to go over what that it means, and it will depend on the type or the group of people or patients that we are going to have conversation with. If you have adolescent patients, the level of physical activity is not the same if you are talking to a senior or if you're talking to someone with a disability. And another issue that we always add to the personal history, but sometimes we don't pay attention to, is alcohol consumption. We know that alcohol also has is one of the reasons why people can be overweight or obese and have other liver diseases as well. So let's make sure that we address that we have conversation about these risk behaviors. And if our patients and when you talk to your patients and they have these for low risk behaviors, that's great. So let's just emphasize and highlight what they need to keep doing in order to have a healthy life. Next slide, please. Then there are other issues like the life essentials, how we can talk to our patient about stop smoking, monitoring, eating healthy, making sure that they exercise, that they have vegetables, that they sleep the right amount of time that they need to sleep, etc. This is also very important so our patients don't have the complications or conditions that are associated, when we are not doing any of these life essential. And next slide, please. So these are the life essentials. If you are trying to have a conversation with your patients, if you would like to have some type of resource for your patient when you are talking to them, and you can say you are doing great, but if you are trying to do better, follow these issues. It is not is very important. And in the eight essential is not missing a stress management. Yes, I think that you're right. That's another thing that we need to talk to our patients and assess the mental health. If the patient has any mental health issues, if the patient has some stress, you are bringing something really important, Lisbeth, and is the fact that some of the hormones that we mentioned in the very beginning, as part of the pathophysiology of being overweight or obese, is linked to stress, and depression. So yes, you are right on that. Thank you so much for your comment. Next slide, please. Then we have also the 6 pillars of lifestyle medicine, similar to the 8 essentials, things that we can recommend to our patients. In this one, Lisbeth, you see the loto flower. So that is more like making sure that a patient are following, any type of a strategy to decrease anxiety or stress in their lives. And next slide, please. Let's make sure that we talk to our patients about their condition. One of the sometimes clinicians don't like to talk about obesity or don't like to talk or don't have the time because sometimes they are very busy, they have more patients, and they cannot take like few minutes to have a conversation with the patients and making sure that if we develop any program that is a nutrition and exercise program, we refer our patients, so making sure that they receive the recommendations and the advice that can be provided in your clinics. Next slide, please. This is another resource similar to the 5 A's and the other and the 8 essentials. Let's make sure that when we are talking to our patients, we need to be empathetic. We are going to go over this in the next session regarding on when we talk about stigma and when we talk about motivational interviewing. And let's make sure that the patient find a motivation, something that the patient, a reason why the patient wants to lose weight. We need to help them to build confidence. We see many people that because of the stigma or because stereotypes, they don't have the confidence to start a nutrition program or an exercise program. We need to set smart goals and set an accountability plan. And we can say, in our next session, we need to have this completed. If not, let's reevaluate and let's reassess the plan that we have developed together, and making sure that we follow this coaching model as well. Next slide, please. When you're talking to your patients, and this is how we can prepare, discussion with patients on weight management. Let's make sure we've been talking about challenges, for instance, and you need to make sure that the environment, the clinic, has all the necessary tools and equipment to help the patients, that so the patient doesn't feel uncomfortable, that you have a waiting area, you have the furniture that you need, the medical equipment, and let's make sure that we know exactly what the patient is looking for. Make sure that we avoid some language like don't say obese or fat or morbidly obese or overweight status. Let's try to use a language that is more friendly, so the patient, that we can create that cordial environment, and the patient feels that they are in a place where they are appreciated and they are not being judged or being accused of being obese or overweight. Next slide, please. This is just a resource as well on how we can see the different interaction, the social interaction, as well as education programs that we can provide to our patients, and different strategies used by health centers and safety net providers. This is very useful if for those health centers establishing food is medicine programs as well. This is a really good resource to review. Next slide, please. We know that this is what the patients need, that we need navigators, we need to work with the clinical team, provide the educational support. We'll be talking about health literacy and the provision of food. Health centers and safety net providers are making sure that the patients receive the food that they need because they have different programs. I've heard from health centers having food prescription programs or nutrition programs as well, and providing food to our patients who don't have access to healthy food. Next slide, please. And this is like an algorithm that we can also use when we start a conversation with our patients, especially if our patients are coming to the clinic for the first time, on how to navigate and how to get to the goals that we have set with our patients. Another resource that you can review and making sure that that if there is anything that you're missing or anything that you would like to adapt, you can use this slide as well that we are going to share with all of you. Next slide, please. We have some challenges when we have conversations with our patients. People call them excuses. In reality, these are different challenges that our patients have. We can hear from our patient, I use food to cope, or I have not met my weight loss expectations, so I don't care anymore, or I often snack even though I am not hungry. So we need to get ready for all these challenges when we have conversations with our patients and making sure that we have a response that we can motivate our patients, to overcome any of these challenges when that they can say when you have conversation with them. Next slide, please. So in the next 5 minutes, let's do an exercise. We have a case study. We have a patient, a 35-year-old female with history of hypertension, prediabetes, waist circumference of 41 inches. The patient has hyperlipidemia, history of diabetes and cardiovascular disease. And with an daughter who is also having issues at school, and there is family history. The patient also refers that are having low stamina, and she complains about her knee, that her knee hurts. And she gets really tired, when she deals with the kids with the whole day. Next slide, please. So the 2 or 3 questions to complete these sessions are: how do we start our conversation with Latasha based on the conversation that we just had? And what weight management plan would you discuss with her? And who in your team would be involved in her care? So if we can go back to the previous slide, just to make sure that we have the information that we need. Please use the chat box, or if you would like to chime in and verbally tell us what you think. You can also use the icon where you can raise your hand and your line will be unmuted. Anyone who would like to tell us something or respond to any of these 3 questions?
I will try.
Okay, perfect. Thank you.
Okay. Hi, Latasha. Thank you for making time today to talk about your health. My first question will be probably what concerns you most have about your health right now or now? Like trying to make an open question for her to share more information on what is in that moment her priority. Or maybe it's also like another follow-up question. How do you feel about your current health?
That's great. Yeah, I mean that's a really good start. You know, there is something that I think that is hidden in the in Natasha's clinical history, and if you go back, Fide or Shimoka, you know, one of the first things that we need to talk to her is about her knee. You know, she's mentioning her knee, and that can be a door for us, you know, to ask, you know, when she started with this symptom and whether this is related to obesity or whether this is related to an accident that she had. We've been talking about the stigma. We've been talking about ideas, and the first thing, if we see a patient who is overweight or obese, the knees are hurting because this person is obese. Is that the reality? Probably not. So that's the things that we need to keep in mind when we have conversation with our patients. And thank you so much, Lisbeth, for your participation. We are going to keep the conversation next week. Feed the next slide, please. Next slide. In the meantime, these are the takeaways for this conversation. Remember, obesity is the first thing you see. Do not make it the last thing you talk about with your patients. And bring obesity to the forefront when looking at your patient's health, making sure that we ask the right questions, you know, to our patients, and making sure that patients understand that weight in general is a priority, that we need to educate our patients and design comprehensive treatment with our patients. And it's not only something that we are going to do, but something that we're also going to discuss with our patients. Next slide, please. And this is information about our upcoming sessions. Next session is on motivational interviewing. Session 3 is going to be on strategies to reduce weight stigma and solutions for physical activity improvement. Right?
I would like to, sorry, Dr. Neal, I would like to make a correction here. Our next section will be on strategies to reduce weight stigma.
Weight stigma, okay.
And then the third session will be on motivational interviewing for nutrition.
Excellent, excellent. So please don't forget to, there is a survey just after this conversation. Make sure that you complete the survey. And if you have any questions or you would like to follow up with any of us, our contact information is on the next slide.
We have a quick question.
Okay, I'm sorry.
Kelly asked, do you feel BMI is the best tool for measuring obesity? And are there any other options on the horizon?
At this moment, is what is recommended, Kelly, by the U.S. Preventive Task Force, is also the recommendation that we have from the Centers for Disease Control. Some slides, the first or second slide that we went over, we saw some definition from WHO as well. But at this moment, here in the United States, BMI continues to be, you know, the right tool or the right measure.
Yep.
Thank you so much, everyone, and have a great afternoon.
Thank you.
See you next week.
See you next week. Thank you, everyone.